Good evening and welcome. My name is Neil Kitchen, consultant neurosurgeon at the National Hospital Queen Square and clinical director of the Queen Square Radiosurgical Centre. Welcome to the first in a series of webinars on the current place of stereotactic radiosurgery in clinical practice. Today, we are looking specifically at metastatic disease. First of all, if I may introduce our faculty. First of all, Mr. Matt Radatz, who is my co-chairman for this evening.
Thank you, Neil. It's a great pleasure to be here.
Secondly, Dr. Michael Kosmin.
Hello, likewise.
And finally, Mr. Julian Cahill.
Thank you very much.
If we could look at the agenda in a bit more detail, please. So the title of the webinar is An Introduction to the Measures of Treatment of Patients with Brain Metastases. First of all, Michael Kosmin, who's a consultant oncologist from UCLH, will talk about Linac Stereotactic Radiotherapy for Brain Metastases and his experience at UCH. After that, Mr. Julian Cahill, who is a consultant neurosurgeon at the National Centre for Stereotactic Radiosurgery in Sheffield, and he will talk on an analysis of diagnostic and treatment imaging in patients with intracranial metastatic disease. And finally, we pass back to Michael Kosmin to talk about the paramagnetic MRI in staged gamma knife for the larger metastases. Now, the webinar lasts an hour only. So after these talks, we want to have a question and answer session, and please do submit your questions, which you'll find at the link at towards the bottom of your web page. The learning objectives for the seminar are listed here, namely, what is the best size of brain lesions as suitable for treatment? What are the number of metastases suitable for treatment? Is there a maximum number or volume of metastatic disease that should not be treated with stereotactic radiosurgery? Where is the place of Linac versus gamma knife in the stereotactic radiosurgical armamentarium? And what are the referral to treatment metastatic pathways? Finally, CPD. This webinar has a claim of 2 CPD credits, and it's simple to claim when you give your feedback of the seminar. So, with no further ado, I think we should crack on with the webinar and go to our first speaker, Dr. Michael Kosmin, who is going to give his talk. Thank you, Michael.
Thank you, Neil, and thank you, Matt, and thank you to the audience. This is a good opportunity for me to present to you some information about how we use the linear accelerator for stereotactic radiotherapy for brain metastases at UCLH. So, in our centre at UCLH, we are twinned with Queen Square and the Gamma Knife Centre there, and the vast majority of the stereotactic radiotherapy for brain metastasis in our service is undertaken with the gamma knife. But there is a small proportion of patients who are deemed not so suitable for treatment, and these are the patients for whom we deliver their stereotactic radiotherapy with our linear accelerators. And that essentially is for those patients who we are offering post-operative tumor bed irradiation in cases of residual disease or local recurrent disease. We deliver this treatment as a fractionated treatment. And to illustrate this more clearly, I've got an example case that I'll take us through, which will hopefully illustrate how the different techniques can be used. So the case example for us this evening is a 64-year-old woman who was diagnosed in October 2016 with ovarian cancer. So a stage 3C endometrioid high-grade carcinoma of the ovary. So a high-risk disease, but not one usually associated with brain metastasis. She underwent appropriate local multimodality therapy, including extensive surgery, adjuvant chemotherapy, and then she went on to post-treatment surveillance. Almost 3 years later, she presented via her GP with a short history of headaches and memory problems and was referred to her local neurosurgical centre at Queen's Hospital in Romford, just east of London. And when she presented in early September of last year, this was her diagnostic MRI scan. And as most of the audience will probably be aware, this is the 3 planes of view of a contrast-enhanced T1 weighted MRI scan. And this shows a large enhancing lesion in the left frontal area, which is clearly visible on this imaging. So the local neurosurgical team took her to surgery the next day, performed a left frontal craniotomy and completely resected this solitary metastasis. And the histopathological analysis confirmed that this was consistent with a metastatic deposit from her previous ovarian cancer. So that was in early September. 2 months later, she had her early follow-up MRI scan. And this shows a small recurrent nodule or potentially residual disease in the surgical cavity, which is illustrated by this red arrow on your screens. And at this point that month, the patient was referred down to us at UCLH in Queen's Square for consideration of focal therapy, by which her referrers essentially meant Gamma knife. And at this point, we discussed the patient in our meeting and felt that there was an area of small residual disease that would be suitable for focal treatment. And we then went forwards to see the patient in clinic and with the aim to offer Gamma knife treatment. The patient came to clinic a week later and underwent a Gamma knife planning scan later that same week. So by now we're in the first week of December 2019. And unfortunately, the residual disease was now significantly bigger. There was multiple nodules present within the surgical bed, and we felt that this was no longer suitable for Gamma knife treatment, but that the whole surgical bed required radiation treatment. So there'll be further images that will show you that more clearly shortly. So in terms of our dose fractionation schedules for linear accelerator-based treatments, we do have a single fraction schedule for small brain metastasis, but as I've explained already, this is really where the Gamma knife is used in our center. So we don't really offer this treatment to patients on the linear accelerator. However, the following dose fractionations are used for patients like the one in question. So a fractionation of 25 grain 5 daily fractions over 1 week for large solitary metastasis, but particularly tumor bed irradiation. There is a slightly more hypofractionated treatment, which is delivered Monday, Wednesday, and Friday of the same week for large target volumes in younger patients, particularly if they are away from organs at risk or sensitive structures. And then there's a slightly lower dose radiation, 20 grain 5 fractions daily over 1 week, which we use for re-irradiation or for lesions that are particularly close to more sensitive organs at risk. So how do we define our target volumes? And so this is a kind of bit of clinical oncology bread and butter for us this evening. So our gross tumor volume, or GTV, is defined as our gross residual disease. And in this case, if there's evidence of a rim of enhancement, that enhancing disease forms our GTV. Our clinical target volume, or CTV, is formed from our GTV, but expanded out to include the resection cavity. In this case, you can see that as the yellow margin and volume defined in the image. And then we add a 1 millimeter margin for our planning target volume, which essentially allows us 1 millimeter of setup error for the patient. Given the proximity to the orbit and the anterior visual pathway, this patient was prescribed 25 grain 5 fractions over 1 week. So these images will be a little more helpful to show you the disease as well. So first of all, the axial slice. So on the left, it shows the target volumes, as I've shown on the previous slide. And to the right is our radiotherapy plan. Now, different to the Gamma Knife, our radiotherapy dose is prescribed to 100% with the aim to give 100% across our target volume, expecting a hotspot using these techniques of between 120 and 140%. This is perhaps a better image than we saw previously of this residual disease on the left that had grown above the left orbit there in the surgical cavity. And on the right of this image is again our radiotherapy dose as it was delivered, in this case to the 50% isodose. So you can see how the conformality of this treatment is different to what you may expect to see on the Gamma Knife. And finally, in the sagittal plane, again, looking at our target volume and its proximity to the globe and the optic nerve on the left-hand side. So this was the clinically treatable plan. So then how is that delivered on the linear accelerator? So for those of you who don't know, the linear accelerator is a different setup to the Gamma Knife. The patients are immobilized with a thermoplastic shell, and the linear accelerator, using the rapid arc technique, rotates around the patient, in this case in a partial arc, delivering intensity modulated radiotherapy to this target volume. The image on the right there may help you understand how the geometry works with the image on the left. So what happened to this patient? So this is their immediate post radiotherapy scan, by which I mean approximately 8 weeks after treatment. That nodule of disease that you can see on the left-hand side of your slide there on the left-hand image has resolved, and there's no enhancing disease evident on that. The image on the right shows no enhancing disease on the coronal, and there are further clinical updates for this patient. So this patient has continued to respond well to her radiotherapy treatment. She has recently had further imaging this month, which again shows a complete response to her radiation treatment with no evidence of residual or recurrent disease, and clinically she remains well. So in summary, this is a patient who was originally presented with a large metastatic deposit, which was managed surgically. There was then concern about a small nodule of recurrent disease for which Gamma Knife was thought to be the most appropriate modality of treatment. When she came for Gamma Knife planning, it became apparent that she'd had quite rapid progression throughout her surgical bed, for which we felt that linear accelerator-based treatment to a larger volume was more appropriate. I've taken us through how we have planned and delivered that treatment, as well as the outcomes here, which for this particular patient have been good. So that's my introduction, I suppose, to linear accelerator-based stereotactic radiotherapy. And when it comes to questions later, I'm happy, of course, to take any questions about the delivery of these treatments and how they may be different or similar to the other treatments that we'll discuss this evening. Thank you very much.
Thank you, Michael. It's good to see that you show the place of resective surgery in this situation, and the advantages, but also the problems with it as well in terms of local recurrence. But no doubt we'll talk about that later on. Can I just remind everybody to please submit questions? There is time at the end. We really want to hear what's bothering you. Fine, so I'm going to hand over now to my co-chair, Matt Radatz, who will introduce our next speaker. Thank you.
Thank you, Neil. It gives me a very great pleasure to introduce my colleague, Julian Cahill, to give the next talk on an analysis of diagnostic and treatment imaging in patients with intracranial metastatic disease.
Thank you very much, Matt, for that kind introduction. So I wanted to share with you a study that we carried out looking at the differences in the diagnostic or referred scans compared to what we found on the treatment day. And in Gamma Knife, or using Gamma Knife SRS, we carry out a scan on the day of treatment. So many of you will be familiar with the background. As you know, the global incidence of cancer is increasing, but mortality rates are falling. In part, that's due to improved detection, but I think more importantly, as a result of the new lines of systemic treatment, and in particular immunotherapy. And for example, melanoma has made amazing advances over the last number of years. So some protocols, in addition to that, such as the NICE guidelines for lung cancer, in particular stage 3, advocate an MRI brain for all patients, whether they're symptomatic or not. And we have seen some of those patients now coming through the pathway looking for treatment. So we estimate that about 40% of all cancer patients will develop intracranial metastatic disease. It gives about 2,000 patients a year requiring some form of SRS. And interestingly, it is likely that these patients will present with multiple rather than solitary lesions. So between January 18 and January 19, we identified 197 patients across not only our own centre, but also our sister site in Thornbury. We excluded 12 of those due to inadequate imaging, leaving 185 patients encompassing 200 individual treatment plans. So 15 of those patients were treated twice. 2 were not treated, and 12 had stage treatments. That would either be for volume or for total number of individual deposits. And as suggested in the previous slide, we found only 19% of our plans were for solitary lesions. So we accepted either a 1.5 or 3 tester volumetric post-contrast T1 scan with a maximum thickness of about 2 millimeters and a gap of 2 millimeters. As you can see from the slide, the actual mean was considerably less than that, but these would have been scans carried out from the various hospitals around the country referring those patients in for treatment. In comparison to that, our own scan again was 1.5 or 3 Tesla, but we did use double contrast, and I'll come back to that later on. Our scan thickness is about 1 millimeter thick and there's no gap. So hopefully, as many of you will be aware, the NHS commissioning criteria includes an overall volume of 20 centimeters cubed, a prognosis greater than 6 months with absent or controllable disease, and a KPS of 70. Now, we tend to use a WHO performance score of 0 to 1. But for those of you that are aware of both of those, the WHO performance status of 2 does also come in with a KPS of 70. So if you're a good 2, as it were, we'll take you on as well. So all 185 patients met the criteria, which I suppose is not surprising because these all would have been post-MDT. So in other words, the MDT would have ruled out those that weren't suitable. So 2 patients were not treated, one having 75 lesions with a volume, overall volume, which was greater than 20 centimeters cubed. Another had 53, and despite the volume being less than 20 cc's, it was felt that that patient was not appropriate for treatment. And a third patient with 13 had a volume much greater than 20 cc and was treated. Needless to say, the volume was not apparent on the referral scan. So the patient demographics show a fairly even split between male and female, with about 45% of the cohort being greater than 65 years of age, and the usual suspects with regard to lung, breast, melanoma, and renal. About a quarter of the patients had surgery, another quarter had SRS, and less than 10% had whole brain radiotherapy. And obviously we are now seeing a reduction in patients who are being offered whole brain. So what we found was, with a 7-day delay between the diagnostic and treatment imaging, 45% of patients had new, previously undiagnosed tumors. This figure rose to 54% with a 2-week delay. After this time point, you can expect an exponential rise. And if you're looking at 3 and 4 weeks, overall, you'd expect 70% of your patients will have at least 1 new deposit, if not more. So this graph simply demonstrates that, as expected, most patients with new lesions will be few in number, between 1 and 5, and that's demonstrated by the blue area in the graph. However, even after just a period of a week, a few of the patients will present with anything up to 10 or 15 new deposits. Obviously, if you go on week by week, you expect those numbers, which is you can see in the red and orange coloring on the graph, to increase in size, demonstrating that there are more and more patients presenting with new tumors. We also found substantial increases in the volume of the metastatic deposits that we were aware of from the referring scan. After 1 week, the volume increases almost 30%, and by 2 weeks, that rises to 40%. After that, the rise is very significant, as you can see, 150, even up to 200% change in volume in week 3 and week 4. As expected, most of these increases tend to occur later in that time period. And again, in this particular slide, the blue is greater than 29 days. And you can see at the bottom of the graph, the volume of the metastatic lesions, when you're looking at in excess of 4 weeks, is starting to approach 1,000 millimeters cubed. While I realize that this slide is specific to Sheffield, which it is, I thought that the results would be useful from the point of view, depending on the platform that you're using, that you can see that even a planned treatment day, and we tend to treat anything between 3 and 4 patients a day, with increasing number of METs found on the day, can prolong treatment time significantly. That has significant consequences not only for your staffing, but your treatment pathways. Most of our patients we treat as a day case, and sending them home late at night is just not appropriate. So all of this does need to be taken into account, and so therefore it does have quite significant effects. We did look at the sources of delays between, for example, referral and the treatment scan. The referral letters or emails were available in 88 of those patients. We found an average delay of about 5 days. That's simply to make the referral, which seems a bit excessive. On occasion, that extended out to 20 days. Once the referral was received, the time to the MDT was about 4 days, and from MDT to clinic about 7. Largely incomplete information, and on occasion surgery accounted for the delays. In other words, you were waiting for patients to recover. And then once seen in clinic, patients were on average treated within 5 days. Again, histology accounted for some of the significant delays seen. So as you can see, the range went from a single day to 35 days. The most obvious source of bias is the use of double contrast, and I accept that this will account for a proportion of new lesions, but I do not think that it accounts for all of them, and nor does it necessarily account for the changes that we see in volume. So in summary, based on this study, we can estimate that overall 65% of patients will have new lesions on the day of treatment. 54% of those will be within 2 weeks. And obviously, if you can get a scan and get a patient all the way to treatment within 2 weeks, then you're doing very well. So most people will extend beyond that period of time. And that the volume increases in the known tumors will be seen between 30 and 250% if you're going out at 4 weeks. So it's fairly clear that improvements are needed to expedite treatment. I think that referrals can be improved by including patients' performance status, current disease options, including restaging where appropriate. Accurate knowledge of the number of lesions that you're going to treat will obviously improve your treatment planning and logistics. And then I suppose the last thing that I'd like to mention is with regard to pre-planning. And there's certainly a risk that tumors will not be treated depending on the time or the period between your scan and your actual treatment being administered. That even with a fairly generous PTV, I think some tumors may be undertreated depending on the length of time between the planning and the treatment. The consequences of that we're not sure of. I don't think anyone has ever looked at that significantly, but it is, I think, a cause of concern. So thank you very much for your attention, and I'll hand back to Mr. Kitchen.
Thanks very much, Julian. We'll come back to you at the end with specific questions.
Thank you.
So I hand back to Matt, who's going to reintroduce Michael. Thank you.
Yeah, thank you, Julian. That was a fantastic talk. And Michael is giving us a second talk now on the multiparametric MRI in staged gamma knife for larger mets, which will be very interesting to hear. Thank you.
Thank you very much, Matt. So this talk's slightly different. So this talk's got a bit of a research twist to it. Julian mentioned the fact that in the cohort of patients that he's presented, there was a small number that received staged gamma knife for larger metastases. And so my talk will just briefly go into that in a little more detail, but also moving beyond that towards a study, a research study that we are looking to set up at Queen Square, which will hopefully be opening soon, COVID permitting. Okay, so staged gamma knife, this is something that we are using, I would say, more regularly now than previously for larger metastatic disease. And what does staged gamma knife mean? So in our practice, it means usually 3 separate treatments delivered with an interval of between 2 and 3 weeks between fractions. More often than not, 2 weeks between fractions. And that's a slightly different treatment paradigm to those that we would usually use both for stereotactic radiosurgery, but also for fractionated radiotherapy. A 2-week interfraction interval is unusual and opens up some interesting research possibilities. So when and why do we use staged gamma knife? So in our center, we offer staged gamma knife for patients who essentially have either large metastases that are borderline for volume in terms of fitness for treatment, and those that are in particularly difficult to treat or high risk locations, or those with significant evidence of vasogenic edema that may not have responded as well to pre-treatment dexamethasone as we would have hoped. Clearly, giving a staged treatment allows for a slightly softer approach in some ways for these patients who may well otherwise run into treatment-related toxicities. So in our practice, we use 3 10-gray fractions, as I say, with usually a 2-week interfraction interval. And what becomes clear when delivering these treatments, even after the first initial 10-gray of treatment, is that we often see significant signs of response when it comes to the second and third treatments. And the images you see on your screen are one case example of this, in this case, a patient with breast cancer. So by the time the second and third fractions come round, the volume of treatment is often substantially less. That obviously allows us to reduce our treatment volume and therefore reduce the dose to what would otherwise be treated normal tissue. And it allows us to individually adapt at stages 2 and 3 based on the patient's own response to their first and then second treatments. So this is a slightly different example. This is an example of a patient who has a brainstem metastasis, and the images here at treatment 1 and 2 at the top and 3 at the bottom left, I would say don't show the same level of response to the one on the previous slide, but the bottom right image is a follow-up post-gamma knife treatment MRI scan performed at 6 weeks after the third treatment, which shows a more significant response within this brainstem metastasis. So although we often do see changes during the course of the treatment, often we see later responses as you would expect. So giving staged gamma knife, as I kind of intimated, gives us the opportunity to ask some research questions. So what is happening biologically within these lesions between these treatments? And can we define or postulate better ways to distribute dose, particularly at the second and third treatments, based on the changes we may see on imaging within the treated lesions. And multiparametric MRI is one tool that we have that could help answer some of these questions. So rather than the purely anatomical sequences that we are used to using for our radiotherapy planning, there are alternative and additional sequences which kind of fall under the umbrella of multiparametric MRI, which allow our neuroradiologists to provide us perhaps with more information around the biology of what's happening in and around these tumours, with particular interest regarding perfusion and the cellularity of the tumours, particularly using diffusion-weighted imaging, as well as actually having a look at the tumour microenvironment with CEST imaging or spectroscopic imaging. And the picture on the right here is taken from a publication that you can see the reference for, looking at CEST amide imaging of a treated metastasis. Now, the multiparametric MRI imaging, often the resolution of what we receive is significantly inferior to our anatomical sequences, but nevertheless, it does provide us potentially with the opportunity to identify areas of these staged, of these lesions treated with staged treatment that may be responding less well when it comes to the second and third treatments, with the potential perhaps for looking at distributing the dose differently as a result. So the study that we are hoping to open very soon at Queen Square is an imaging study using a full multiparametric MRI of 10 patients undergoing staged gamma knife. Many thanks must go to Amethyst, who are kindly sponsoring the imaging on this study. And so what are we hoping to do in this study? We are offering 10 patients these full multiparametric MRI scans before their treatment. The standard gamma knife planning imaging will, of course, be taken and used for their treatment as normal. There won't be any adaptation of treatment for these patients. This is purely an observational exercise, and we will repeat this process at each of their 3 fractions of gamma knife treatment, looking for changes on the multiparametric MRI within and around their tumours, using the different parameters that we can identify to establish whether or not we see a homogeneous or heterogeneous response. And that will then allow us to perform some in silico studies of how we may in future wish to adapt doses to try and achieve better outcomes for these patients. Of course, we will also be keen to undertake a follow-up multiparametric MRI scan for these patients 6 weeks after treatment to assess for their response alongside their standard MRI that would usually be performed at this time. So as I say, this is a study opening in our centre soon, and I'd be keen to get the comments and questions of those of you participating online with regards to this. Thank you.
Brilliant. Thank you so much, everybody. Now we come on to the question and answer section of the webinar, and I'm pleased to say we've got a number of questions coming in, so I will describe them and read them out, and perhaps just select a member of the panel to start with, if that's okay. The first question is, how to overcome a patient who has peripheral metastases that could prevent using gamma knife due to clearance issue? Do you have to use the Linac in this case? So in other words, are there any situations intracranially where you couldn't use the gamma knife for, not size wise but position wise? Perhaps I can ask Matt to ask that question after that.
Yeah, well, I think that entirely depends on what gamma knife model you're using, and there would have been problems on the even potentially on the B and C models. On the new Perfection and on the Icon, I don't think you have that limitation and problem anymore, because you have a wider range, and you are in a position to treat very superficial anterior, posterior lesions all in one session. So we don't have on the newer models that issue, but in the older days, that could have been an issue, and on the B and C model, you will still have that issue potentially, yes.
As long as I suppose the frame or the mask has been fitted properly to include so the scan includes all the intracranial compartment, of course.
Yeah, that's correct, yeah.
Okay, the next question is a more general one, and perhaps I can ask Michael to kick off with this. Has there been a shift away from the use of whole brain radiotherapy in the treatment of cerebral metastases?
There's a short and a long answer to that. I think the answer is certainly yes. There's a move away from whole brain radiotherapy, but I think it would be wrong to assume there is no place for whole brain radiotherapy. And I think certainly in our MDT meetings and our case discussions, we do have patients who have previously received whole brain radiotherapy, occasionally some time ago, who have responded very well to that. And although at the initial time they were offered that treatment, they may not have been suitable for focal therapy. If they've had an excellent response and subsequently have a small volume of progressive disease intracranially, it may be appropriate for these patients to be offered gamma knife. I have to say, we are getting more referrals from our colleagues, oncology colleagues, for patients who may previously have been offered whole brain radiotherapy, at least for us to consider them for stereotactic radiotherapy. And in our centre's case for gamma knife, there is good evidence that whole brain radiotherapy leads to some increase in toxicity, particularly neurocognitive toxicity that the audience will probably be well aware of. And so the option for focal therapy for brain metastases is preferred. I'm not sure what the rest of the faculty would like to say.
Matt, what about your experience? What's your feelings about whole brain radiotherapy?
I think there's a role and remains a role for whole brain radiotherapy, in particular in these patients who have what I would call milial brain disease, small, huge number of small lesions. And like Michael described, if they respond very well to that initial whole brain radiotherapy, then there might be a good reason to treat and pick up failing disease or progressive disease in very small numbers later on at a radiosurgical boost treatment, for example. And that's what we usually would recommend in patients like Julian described, who had large numbers of lesions exceeding the 20 cc volume, numbers of 70 or 50 plus. And I think it's important that one goes back to the drawing board, but whole brain radiotherapy certainly should be still in the game.
Thank you very much. The next question says, edema in the metastasis, do you include in the CTV or not? So I'm going to sort of change that to be slightly more general. To Julian and Michael, perhaps Julian first. In gamma knife for metastases, malignant disease, is there a difference in philosophy in terms of the margin you would use or the dose fall off that you would use as to compare with benign disease?
I mean, first of all, certainly the edema is not included in your target or your planning. We'd obviously be very much aware of a patient coming in with significant edema and neurological deficit going with it. Obviously, when you're dealing with metastatic disease, you really would want to be very hard pressed to consider decreasing the dose because there was significant edema. I mean, for example, for something like a meningioma, and particularly convexity meningiomas, where quite often a significant edema, then I think you could consider dropping the dose slightly and still maintain a good treatment plan and a good outcome for the patient. Doing it with metastatic disease, as I said, I'd be less inclined. Obviously, we would use steroids, and we would have presumed that many of those patients would be coming either saturated with steroids already, But if not, then we would start steroids.
Yeah.
You could consider reducing the dose. Like, for example, we would treat an average metastatic deposit with 20 gray, for example. You could probably reduce it down to 18 gray and still get a similar response, but I would be less inclined. Particularly, I mean, if they're big tumors with a lot of edema, I don't think you have a choice, because obviously, giving your patient a deficit is the worst possible outcome. So if my back was to the wall, yes.
I mean, I suppose what I'm saying, Julian, is in malignant disease, perhaps the treatment plan doesn't have to be so tight around the target.
Well, for metastatic disease, I think it does. We don't necessarily want to be we won't add a PTV from, and this is purely from a gamma knife perspective, obviously, and obviously it's very different if you're using Linac, etc. But we certainly won't be looking for a PTV, and we will look for 100% coverage, but we really wouldn't look to exceed that at all.
Okay, thanks, Julian. Michael, what about you? What sort of margin do you use now, particularly thinking about when you're treating the resection cavity when there's nodular recurrence around it?
Yeah, so it's a very good question. So we would not routinely incorporate peritumoral edema as part of our clinical target volume. In terms of post-operative tumor bed radiotherapy, like the case that I presented earlier, the clinical target volume would be the surgical bed, incorporating, of course, any abnormal enhancing tissue, but we would not put a margin around that for these treatments in the same way as we obviously would do for a linear accelerator-based treatment for a primary brain tumor, which is treated in a completely different way in that sense. So in essence, no, we do keep our volumes small and our margins tight, and we treat the edema with steroids, as Julian's described. The thing I would add to the discussion about benign and malignant disease is that occasionally malignant lesions are perhaps less clearly definable around their edge than some benign lesions would be. And following on from your earlier question, Neil, I think occasionally you may err on the side of caution a little bit when it comes to making sure you are fully covering a metastatic lesion, which may not have a nice smooth edge like a benign lesion may sometimes have.
Great, thank you both. That's very clear. Then there's a question which is very specific, and perhaps Julian, I can ask you this. In the SRS planning MRI, what is the delay for imaging after giving contrast? 15 minutes or more, question mark? And is there any evidence for delaying it more if you're giving double contrast?
So I think we wait up to about 10 minutes post the contrast delivery until we take the scan. And you do see quite often from other hospitals when they're referring those original MRI scans in, and you see very little contrast at all, even from the point of view of single contrast. And you can see that they gave the contrast and literally took the pictures seconds later. So yes, I think there is quite a lot of merit behind waiting that period of time before taking the scan. The question of double contrast and then how long do you wait? I mean, I suppose there's no real answer to that. For example, should you go to triple contrast? Some of the Americans do. How long should you wait? Should you wait 15 minutes? Should you push it to 20 minutes? Do you get more? Do you get less? I mean, we certainly feel that we're picking up those very small millimeter type tumors that allow, and obviously again, gamma knife allows you to pick those off as a sort of a spot welding technique to be able to treat those very small tumors. As I said, I think 10 minutes is reasonable. Whether that would improve with extension, we didn't find so. We didn't find that was the case. But I'm aware that other units do try and push it a bit longer.
Thank you. Can I indulge myself with one question to you, Julian? That's on your talk. Is is there a certain amount of time when you insist or strongly recommend to your referrers that they repeat the MRI scan before you're accepting the patient for Gamma Knife?
There are. We have two ways of doing it. On the one hand, yes, ideally, if you're referring a scan in that's anywhere between 4 and 6 weeks old, we would look for that to be repeated before making a final decision.
Yeah.
At the 4 weeks, if you're talking about a patient with a large number of tumors, quite often to save delay and to bring the patient in and get on with things, we'll repeat an MRI scan on the clinic day.
Yeah.
Before we make that decision. It obviously depends on how quick your referrer is. I think one of the key things is that you don't have this correspondence going back and forth between the MDT and the referring team. Can you do this? Can you do that? And weeks go by, and I don't think that works for the patient. So, as I said, a lot of the time, if there's any question or if it's towards the 4-week mark, we'll actually do the scan ourselves on the day in clinic and let the patient know what exactly we're looking to treat or not treat.
Thank you. Now, we've got quite a lot of questions coming through, so we're going to carry on. This is for Matt. Perhaps this webinar is not about outcomes in particular, but there's 2 questions on outcomes related to: is it any different with staged Gamma Knife versus single fraction, and is there any difference between 1 to 5 METs and greater than 5 METs? So could you give a general perhaps overview on your take on outcomes, Matt?
I think there is undoubtedly a difference in outcome. I think patients who have lesser metastatic disease by nature will fare better. That's one of the reasons why this is how NHS commissioning for metastatic disease started for radiosurgery. In the early days, we were just allowed to treat single METs. Then that was expanded because of very good outcomes to up to 3 METs. And then it took quite a few years to show the evidence and produce the evidence that actually it is not so much the number up to 3, but that the overall volume has a role to play in the control of the disease and outcome as well. So that is with regards to numbers. But recent times have changed outcome in metastatic disease, and in particular due to the adjuvant therapies, immunotherapies available for different diseases. And so what was a very fatal and lethal disease, intracranial metastatic deposits from melanoma, for example, the outcome is much better now. And the most favorable one, from my point of view, is a receptor-positive breast cancer, which means that we are able to control intracranial disease. And we have many patients. I have a breast patient who had 5 treatments of over 100 METs over 6 years and is still alive without neurological deficit. What the main issue for outcome is the control of the peripheral disease. Yep. The majority of our patients do not die from their intracranial disease. We can control the intracranial disease with repeated radiosurgery very well. They die from the peripheral disease, and that is a guiding factor, really. And that is why it is so important that these patients are discussed in an MDT.
Thanks very much, Matt. Okay, the next question is, if we are seeing new lesions in patients on the treatment day, if treatment is given early, presumably these new lesions will continue to appear after treatment. The NHS criteria does not allow patients to be treated within 3 months for new lesions. How can this then be managed? Should we wait before treating if lesions are small, or still try and treat as soon as possible?
So I presume that's for me. Yeah. So if you're looking at the information that I provided, and that we're seeing that the number of metastatic deposits is increasing over time, certainly my feeling would be that you would treat everything that you could see. Yeah. Ideally, you should be looking for those very small metastatic deposits. And I know that many centers may not necessarily look for them because they feel that they can't treat them anyway. So some centers will have a size limit as to what they feel that they can treat. using gamma knife, I don't think that limit is there. You can treat literally anything. Yes, the NHS has suggested that there would be a 3-month period in between treatment gaps. For the point of view of our patients, once they are treated, they all have a repeat MRI scan at 3 months anyway.
Sure.
So if there was something that you missed or didn't respond to treatment, you would see that again in 3 months' time. It doesn't make any sense to me personally to see a very small metastatic deposit and decide, well, let's just keep an eye out and see what happens. I mean, I think we know what happens. And then how long are you going to wait? Are you going to wait a month or 2 months or 3 months before you decide to treat it? If you have the technology, I think they should be treated.
Thank you very much. This next question is for Michael. A melanoma patient who's on immunotherapy and develops 2 brain metastases. Had good response to extracranial disease with the immunotherapy, and the doctor wants to continue with the immunotherapy after SRT. What is the potential interaction between SBRT and immunotherapy?
So that's a good question, and that's something that we're dealing with more and more for all the reasons that the panel has explained in terms of the systemic management of these diseases. So there is a concept called the abscopal effect, which is particularly pertinent to melanoma patients on immunotherapy, whereby ablative doses of radiation to sites of disease, whether that be intracranial or extracranial sites of disease, cause an immune reaction and can increase antigen presentation, which may facilitate the benefits that these patients are getting with their systemic immunotherapy. So in terms of how would you combine the 2 treatments for a melanoma patient, our practice is to do exactly that. It's to combine them, i.e. Offer these patients who are appropriate for treatment based on all the criteria we've touched on, offer these patients stereotactic radiosurgery to their sites of brain metastatic disease, sequenced alongside their regular immunotherapy treatments. In terms of additional toxicity, our patient groups have not struggled particularly with that, and overall, our referring melanoma oncologists are often very keen for us to treat these patients, even with small metastatic lesions, for those reasons.
Okay, thank you. Another quick question to the panel. What is our experience with prostate brain metastases? So this is a sort of a pathology question. Are there some pathologies, primary cancers, which respond particularly worse or better than others? Who would like to comment on that?
Well, I'm quite happy to.
Matt, go on, I choose you.
Yeah, I'm quite happy to take that question. It's a very rare disease, prostatic brain metastasis. I have to say, I cannot recall a single patient I treated from a prostate metastatic deposit in the brain. But in that context, it's difficult. We treat many patients a year in Sheffield, but it's very rare. And I think it's because it is so rare, I would guess that this is actually a very negative factor if a prostate patient develops brain metastatic disease.
Yeah. Thank you. I think we see them very occasionally. Yeah, so it's difficult to generalize, isn't it? And then a very interesting question's come in, really, for both Julian and Michael. It's a general question. So when you plan with the Linac, I understand the planning scans might be done a little while before the treatment day. Does that have any implications about the tumour volume might have changed by the time you come to treatment, and how do you handle that situation? Perhaps Michael, it's fair to ask Michael that question.
Yeah, so thank you for the question. So following on from Julian's talk and his very clear presentation of the data of how the volume of these lesions changes quite quickly, a gap between planning and treatment becomes very relevant, doesn't it? However, certainly in our practice, as I've illustrated it, we tend to use our linear accelerator-based treatments for tumor bed irradiation. Now, clearly within that, there needs to be an element of macroscopic disease, but often our overall target volume is more extensive than the gross tumor volume. So by the time we've covered the whole of the tumor bed and put a millimeter on top around that of our planning target volume margin, that provides us with a little more wiggle room, so to speak. I think certainly for centers that use linear accelerator-based treatments for the bulk of their brain metastatic work, whereby they may have a gap between their planning scan and the first treatment delivery, that may well be more of an issue. But the linear accelerator tends not to be a particularly good treatment for multiple small metastases. Julian.
Yeah, I mean, absolutely. Logically, there would be a concern that with the data that I presented, that you're either not treating some of those small tumors, and you may argue, well, if you don't, you'll pick them up on the next scan or whatever the case may be, and fine. For those where there's a significant increase in volume, the risk is that you're under treating. Logic doesn't necessarily bring you beyond that point. In other words, what we're really interested in is there a difference in outcome between, so for example, a gamma knife that's scanning on the day versus a Linac that's using pre-planning. Of course, it depends on what period of time. We talk about a week or 2 weeks. We're also talking about what sort of imaging people are pre-planning on. So, for example, some people will be using CT rather than MR. And again, you're not going to find those particularly small tumors. So the outcome is what I think is important. And I don't think we necessarily have the evidence for that as of yet. Certainly to my knowledge, there's no significant prospective trial looking at outcomes across the different platforms, although attempts have been made in the States to try and do that. None of them have been prospective. For those that have had looked at the different platforms, it was rarely with metastatic disease. It tended to be with other forms of pathology. So, I mean, I think the answer is yes, logically, it's of concern, but whether it realistically is or not, at the end of the day, we don't know the answer to that question yet.
Thanks very much. And indeed, thanks very much to the whole panel. We've come to the end of our questions and we've come to the end of our time. So I'd like to ask Matt to summarize for us. Matt.
Yeah, thank you very much. I think that was a very well presented talks from Julian and from Michael. I think I really enjoyed the question session and the interesting questions raised and the responses of our faculty. I hope that the audience enjoyed the meeting, and I am very grateful for all the attendees, and hopefully we will see that in the feedback. We are planning to have more meetings like this. This is a premiere, and thank you for Amethyst for facilitating this, and thank you for Neil for sharing it, and thank you for the faculty and all attendees. It was fabulous. Thank you.
Good night, everyone.
Good night.